So welcome everyone. This is going to be my first short foot sesh with Jeff. And basically what I'm going to go through is how I manage and treat people with plantar fasciitis or plantar fasciopathy. And I'll include a few diagrams and pictures along the way. And if anyone wants to use these in their sort of practice or for their patients, just shoot me an email and I'll send through the PDF version. And you can use it for yourself. So let's get started. So this is an overview of, I guess, the complete disease process from going from normal to chronic degeneration to acute inactive and then back to normal. So this is sort of how I normally explain it to the patients, and I'll go through each of the steps one by one. So the plantar fascia is a modification of the deep fascia, and it is made up of primarily of connective tissue. It attaches to the base of the heel and runs along the length of the foot where it blends into the toes. So we're still looking at a normal plantar fascia here. So this is, I found the best way to assess a normal heel is with ultrasound. So ultrasound gives you a beautiful slice of each sort of individual section that you're imaging. So if we're looking at this, you sort of have to flip the heel upside down. So at the top, you've got the skin, so the epidermis and the dermis, and then under here, so this sort of layer in here is the plantar heel fat pad. Then underneath that, you've got the plantar fascia, which is this nice linear ropey structure. And normally the plantar fascia will measure about 3 to 4 millimeters thick when it's not pathological. And you'll see these nice white and black little lines running through it. Underneath this, you've got the calcaneum, and because this is bone, the sound waves being emitted from the transducer can't pass any further, which is why this area underneath is black. So like I said, normally the thickness of the plantar fascia is around 3 to 4 millimeters. Sometimes once you start to see pathological heels, I'll talk about that in the next sort of section. So moving on to what causes plantar fasciitis and plantar fasciopathy. There's the jury's still sort of out on what actually causes this specific problem. The main sort of theories are sort of the loading theory, where there's increased pressure on this area. The other sort of theory is the traction theory, where they think sometimes if you've got a flatter foot or if there's more tension going through this structure, that it can cause sort of irritation and degeneration at the insertion. A lot of the time, I've found that it'll be people where they've started an activity too quickly, or sometimes when there's hormone changes, such as people after they've had a baby, or sometimes going through menopause, or if they've put on a lot of weight and they're suddenly increasing the demand that's needed from the plantar fascia. So normally, I guess during the day, there'll be force going through the plantar fascia, and these little workers, which are designed to represent fibroblasts, will come in of a night time and they'll sort of repair the damage, and then going through the next day, it'll be fine again, and then this cycle sort of continues, and then the plantar fascia, I guess, you don't get any pathology with the heel. So it's when the damage to the insertion outweighs the amount of repair that these little guys can do over night time. That's when you start to get pathology. And a lot of the reason why people get the pain first thing in the morning is that when you're resting in bed, when your foot is plantar flexed, there's less tension going through this thing. And so this starts to repair in this sort of shortened position. You jump up in the morning and basically you rip on it again, and you sort of traumatize the insertion. And so as this trauma sort of continues day in, day out, what happens is the little fibroblast cells that are coming in and repairing the damage sort of get a bit lazy, because they're really realizing, why do I bother repairing this really well when you keep traumatizing it? And so that's when you start to get this thickening of the plantar fascia. So instead of these nice linear fibers, you start to get all of these messy fibers, and sometimes you'll get this little calcific formation as well, which is what people sometimes commonly refer to as the spur. But I found that it's not usually the spur that's the cause of the problem. It's usually the thickening of the plantar fascia. A lot of the time, if you'll have someone who have been told that they've got a spur and they've only got pain in one foot, usually they'll have the same spur in the other foot. So it's really this plantar fascia thickening and irritation that we've sort of got to get right. So going back to ultrasound imaging of the plantar fascia. So again, we can sort of take a slice of the heel. So again, you've got to sort of flip your brain upside down. At the top, you've got the dermis and epidermis. Then you've got this layer of fat, so the calcaneal fat pad, and then under this is the plantar fascia. And compared to the previous image where it was this nice, skinny, regularly organized like a rope, this one you see is a lot thicker, and you've got a lot more black splodges throughout. And normally when you've got plantar fasciitis or plantar fasciopathy, it'll be around 6 to 8 millimeters thick. So you can also see this bone under here, and sometimes you'll see this little sort of spurring sort of happening as well. Sometimes you'll see tearing in the plantar fascia too. I wouldn't get too worried about that. It's all sort of part of this chronic sort of degenerative process. And so what happens is, again, the foot of a night time is plantar flexed. There's less tension in this thing. And when they get up, basically they rip on it again. And this sort of process happens again and again until you sort of get to this sort of stage. And it's this that we've sort of got to fix. So how do we get from something that's chronically degenerate back to sort of normal? So typically when you see these patients, they've had it for like 4 to 6 months, and it'll be thick. It'll just be really just ingrained. And so you've sort of got to figure out a way that you can take something that's really messy, really unhappy, sort of make it acute and active. So you want to wake up the fibroblasts. You want to get these workers back to try to fix this. And then hopefully it'll sort of go back to normal. And there's a few different ways that I sort of found work really well to sort of stimulate the heel. Like I said, there is no sort of one holy grail that will actually, that'll 100% every time get this back to normal. It's sort of about trialing different things and figuring out what's going to work best for your patient. So the way that I normally try to get this from being chronically degenerate to being more acute and active, so that little fibroblasts want to come in and repair the area, with sort of this controlled trauma. So sometimes if you're really good with massage, that can help. I found that shockwave therapy works really well in the first instance. It's basically high intensity sound waves. Laser therapy, I haven't had much experience with this. I don't think it's really the holy grail that a lot of people think that it is, but I've had patients that report really good results with it, and then I've had patients that say it hasn't done anything. The last sort of point of call that I will generally jump onto will be this injection therapy. There are a few things that people inject. It's either PRP, cortisone, or prolotherapy, which is just glucose. I found that the best way to sort of stimulate this and get it back to being acute and active after you've sort of eliminated these also involving peppering. So basically where you numb up the area. So I usually do a tibial block and then basically poke it a lot. So you make one insertion at the back of the heel so you're not increasing the risk of infection. And basically you just make multiple passes through the plantar fascia. Usually I'll inject cortisone, and I found that works really well. But sometimes you'll have people that don't want cortisone, and then you can just offer them peppering, where you just basically go in, move the needle in and out from the plantar fascia. But you can't do this without it being numb because it's very mean. So once it's acute and active, then the next stage is sort of maintenance to get it back to normal. And this little squash bug number 1 will be what I'll be going through on the next page. I found that if you just rely on these things alone, a lot of the time you can make it active again. But if you don't manage it, you don't do the stretches, and you don't support it enough, then it'll just go back to being chronic again. And like with cortisone, usually that'll be like 3 or 4 months if they generally don't do anything else. So typically my first point of call is to get patients to get a more solid supportive shoe. I found that Asics or Brooks are sort of the best ones, but there's other brands as well. You've sort of just got to. I tell patients that it's the wringing the shoe out like a sponge test. So if you can grab a shoe, if you can wring it out like a sponge, then it's not going to be supportive enough to just sort of help support the foot and the plantar fascia. Gel heel inserts can also help a little bit. I found that the chemist ones generally aren't thick enough and they don't have enough cushioning. So this is an important one. So they have to avoid wearing flat shoes. So shoes with a slight heel can help. I found that a lot of patients will wear these really supportive shoes when they're outside, but at home they'll be wearing barefoot, they'll be wearing no shoes, or they're wearing slippers. So those arch support sort of slip-on shoes at home are a great sort of option to break it up a little bit. But yeah, they've just got to avoid being in really flat shoes, because without a heel, you get more tension and more strain through the plantar fascia, and it's that ongoing sort of repetitive trauma that we want to avoid. So massage is another great way to help sort of stimulate the fibroblasts to get them working again and get the fibers back in the nice direction. So you just need something hard and round. Either this is a rolling pin, a frozen bottle, the ones with the little knobbles on it a bit better, or a spiky ball. Basically, you want to roll it along the length of the plantar fascia, and then when you get to the really sore bit, you just want to push down as hard as you can on that area, just to really try to traumatize it. So that similarly, when you injected it or when you did the shockwave therapy, this is sort of to maintain and to keep going at the insertion of the heel. So this next option I tell patients about, but it's very hard to wear one of these Strasbourg socks or a night splint because they are relatively uncomfortable to wear in bed. So the idea is that by holding the foot, I guess, in a dorsiflexed position, you maintain the tension in the plantar fascia over night time. So you're breaking that cycle of you sleep at night time, the foot's plantar flexed, there's less tension in the plantar fascia, you wake up in the morning, you rip on it again, and that cycle sort of continues. So the other thing that I guess tell patients to do is to avoid sitting with the plantar flexed foot. So when they're sitting in a chair, try to have their foot at least 90 degrees or even dorsiflexed to keep the tension in this plantar fascia to avoid the pain when they're first getting up. So orthotics are another great option to avoid trauma to the plantar fascia. So typically I'll make these out of EVA. So I do generally a bit of an arch support, and I'll do an accommodative, sort of almost like a blowout for where that sort of painful area is. And sometimes I'll do a bit of a slip for the plantar fascia. And these work relatively well as long as they're combined with, I guess, a more solid sort of supportive shoe as well. So Alfredson eccentric stretches sort of help maintain and help reorganize the fibers in the plantar fascia. So you're sort of trying to pull them back into the right direction to reduce this sort of thickening. So there is this product called the Fasciitis fighter, which basically helps activate the windlass. So what you do is there's this little knobble on it, so it dorsiflexes the great toe, so it puts more tension on in the plantar fascia. So typically the way that you do these stretches is you go up on 2 feet, so both of them come up off the ground, then you lift off the good one, and then you drop down on the dodgy one, and you go as low as you can. And sometimes I tell people to hold it at the bottom for like 3 seconds, and then sort of repeat the exercise. And usually I'll say to do about two to three times a day, 3 sets of sort of 15. So taping the foot can work relatively well as well. Everyone has their own different way of doing taping. Basically, you're just trying to reinforce the plantar fascia, and sometimes compressing that plantar heel fat pad can also increase the cushioning underneath the heel. And sometimes I tell patients if they're doing a lot of high impact stuff, so if they're like running on a treadmill, running on concrete, sometimes changing that activity. So if they can run on grass, or otherwise swimming and cycling is a good sort of low impact activity that'll sort of help speed this up and get rid of it a bit quicker. Acupuncture and dry needling. Look, I've put this in here just because some people rave about it. I tried it for a while and I didn't really get any results with it, and I found that the results were sort of sporadic, and I couldn't be confident that it would actually do anything. So I personally don't do this, but it's another option that I sometimes tell patients that it might be worthwhile trying this out if they're not seeing any results with anything else. And I guess the final sort of option that I've sort of found for this particular problem is surgery. Typically, this will involve the plantar fascia release, where they go in there and they cut 2/3 of the medial band, so it's not pulling as much. I sort of think that it's the trauma from actually cutting it and then resting it that fixes this, not necessarily the actual surgery itself. But I guess that's just my opinion. But with this particular problem, it's a bit of a prickly pear sometimes. So usually I'll say, look, throw everything at it, add as many of these things as possible before you sort of go down the surgery path. But sometimes, I guess patients need surgery if it's a chronic ongoing issue that's making their life miserable. So I hope you guys got something out of my first short foot sesh with Jeff. So I guess these are the treatments that I sort of use in my clinic. So it's not an exhaustive list of this is what's only available to treat plantar fasciitis. And I'm sure there are many other options out there that people have had success with. This is just what I've found that works well and has worked well consistently. So if anyone wants a copy of, I guess, the PDF, just shoot me this email, jeff@moduline.com.au. And I'd be happy to send through a copy of the pictures at the front and also the treatment guides that I sort of give out. So that was the second half. I've also invented this little orthotic, and so if anyone wants to ask me more questions about this, I'd be more than happy to have a chat about that as well. So hopefully, I guess if everyone likes this sort of session, then I might do a few more on a lot of different other pathologies as well, just to keep them going. All right, well, great. I hope everyone enjoys. Thanks. Bye.